So it's very important to keep our blood or our interstitial fluid, so all of our body fluids, at about 300 milliosmoles. That's our osmotic concentration in order for us to function properly. So the main function of our kidneys is to maintain that body fluid osmotic concentration by producing more urine, less urine, more dilute urine, more concentrated urine. That's what it all comes down to. So osmolarity, you may have had this before, is the number of solute particles in a kilogram of water. That's just the definition. But body fluids have very small amounts, so that's why we use milliosmoles to express our osmotic concentration in our body fluids. So we must be able to adjust our urine concentration and our urine volume in order to maintain our body fluid osmotic concentration. This is where the long nephron loops come in. So remember these nephrons with the long loops that extend deep into the kidney's medulla, those were called juxtamedullary nephrons. And we said those are the nephrons that are important to concentrate our urine. So that's what we're talking about right now, the nephrons with the long nephron loop. So this is called the countercurrent multiplier. Countercurrent multiplier. And countercurrent means you have a current running in different directions. That's what's happening right here in this loop, because filtrate flows in the opposite direction. In the descending limb, it's flowing in one direction. In the ascending limb, fluid is flowing in the opposite direction. Now the descending limb, we saw in a previous video, is permeable to water. So water can leave or get reabsorbed out of the tubules back into this interstitial fluid here. But salt cannot. It's stuck in the nephron loop until we get to the ascending limb. Now the ascending limb is just the opposite. It's impermeable to water, so water is going to stay put, but salt is allowed out. So the difference in descending versus ascending limb is what it allows in, or what it allows out, and what cannot escape, which are opposites of each other. All right, so here's the process of the countercurrent multiplier. It says start here, so that would be a good place to start. So we have an increase of interstitial fluid osmolality, meaning that our osmotic pressure in our interstitial fluid is very high. So that fluid is entering our nephron, and once it gets into this descending loop right here, well, all that extra fluid is allowed to leave because the descending limb allows water to leave. So water leaves the descending limb, and you can see the arrow right here. So when water leaves the descending limb, now the fluid or filtrate in the descending limb is starting to become more concentrated, because water is leaving that fluid. So we get this increased osmolality, or increased concentration of solute, and it just keeps increasing because water keeps leaving as we move down the descending limb. So at the bottom of the loop, we have a very high, you can see the darker color, we have a very high osmolality of filtrate that's going to be entering the ascending limb. Now recall in the ascending limb, it's permeable to salt, but water must remain. So as the fluid rises through this ascending limb, salt is leaving, but water remains, so we get more dilute, look at the color, as we rise up through the ascending limb, which will increase the interstitial fluid osmolality because salt is entering the interstitial fluid. So that's fine, but actually what's driving the water from leaving in the first place in the descending limb is this sodium, or salt, that's being released in the descending limb. So even though the arrow is that way, well, it's actually escaping both ways right through the tube. So imagine this very high salt concentration. Well, that's going to attract the water follows solute, out of the out of the descending loop. And so because this keeps happening, we get a multiplier effect. Because that interaction of filtrate flow in the descending and ascending, you have that interaction between them because of their close proximity. That establishes a medullary osmotic gradient, which is pulling water out of this side because of the sodium leaving on this side of the nephron loop. So that's a positive feedback cycle, and that uses the flow of fluid to multiply the power of the salt pumps. So we see that even better on this image here. It says as water and solutes are reabsorbed, remember reabsorb means leave the tubules, the loop first concentrates the filtrate, then dilutes it. So look at the color. We have concentrated filtrate and then dilutes it. We can go through these steps here. So number one, filtrate entering the nephron is isoosmotic to both blood plasma and your interstitial fluid. We said 300 was normal, so as that filtrate gets forced through, well, the osmolality is 300 as it enters the descending loop. And because water's leaving, now we're getting more concentrated, so our osmotic pressure, or osmolality, goes from 300 to 4 to 6 to 9, all the way to 1200 as we get to the bottom of the nephron loop. So this is the highest concentration at this point. Now water can no longer leave, but salt can. So salt is getting actively pumped out of the ascending limb, and our osmotic pressure is getting more dilute and more dilute. Our osmolality is now going to 700 to 400 to 200, and to look at this, all the way to 100 by the time we get to the end of the nephron loop. So another way to say this is the osmolality is increasing in the interstitial fluid because it's decreasing here in the ascending limb. So filtrate is the most dilute as it leaves the nephron loop. You can see the milliosmoles is 100, and it is now hypoosmotic to the interstitial fluid. Now it's ready to go into the collecting duct, where we'll continue our story in a little bit. So remember, we're in the juxtamedullary nephron, so we don't have peritubular capillaries here. We have vasorecta. Recall that from earlier in the chapter. So this is not the nephron loop, this is the vasorecta, the blood capillaries that are intimately tied to the nephron loop. And the vasorecta is able to maintain that osmotic gradient that was established in that countercurrent multiplier, because the capillaries here are permeable to water and they're permeable to salt. So they're allowing water and salt to enter and leave just depending on the gradient of the interstitial fluid that was established. So we can see in the descending portion of the vasorecta here, we're going to have water leaving and sodium entering, making it much more, making the osmolarity much higher by the time we get to the bottom area here of the vasorecta, and then the opposite happens. We can see water then entering and sodium then leaving, so by the time we get to the vein, we're close to that 300 milliosmoles again. So the blood in the vasorecta, in here, remains nearly isoosmotic, same osmolarity as the surrounding fluid. And that's because the vasorecta are able to reabsorb water and solutes, like salt, into general circulation, and that's not going to undo anything, because we need the osmotic gradient to drive the urine production. So the capillaries are just basically taking and releasing based on gradients of whatever's available in the interstitial fluid. So there's going to be a greater volume at the end than at the beginning, because it's reabsorbing water lost from the descending vasorecta. You can see the water leaving here. Nephron loop and collecting duct, which is not pictured here, but remember the nephron loop and the collecting duct, we have reabsorbed water, and because of those two, we see an actual greater volume at the end of the vasorecta than at the beginning. So if you look at this kidney here, we see a nephron, and this nephron's enlarged, of course, but it really drives home the point. Just kind of keep this in mind, like it says here, and that will help you understand how we make dilute or very concentrated urine. Because these numbers here represent the osmolality in the interstitial fluid. So not in the nephron, not in the capillaries, not in the vasorecta capillaries, but actually in the spaces in the interstitial fluid. We see that when we're in the cortex around here, even at that cortex medulla junction, we're around 300, but as we move deeper into the medulla, the osmolality just raises and keeps raising till about 1200. So once we get to that medulla renal pelvis kind of junction here, we're at about 1200. So it's the interstitial fluid that's increasing in concentration. So remember our collecting ducts right there. The collecting ducts are located in the medulla here, so as we move down the collecting duct, the interstitial fluid outside the collecting duct is going to be higher and higher in osmolality as we move down the medulla. So that will make the next point, or the next little section, a little easier to understand. So that medullary osmotic gradient, which we just saw, we can use that to form dilute or concentrated urine. If we didn't have that gradient, well then we couldn't go over 300 milliosmoles, and we couldn't conserve our water. So if we're overhydrated, we're going to produce a large volume of dilute urine. That's because of ADH production decreases. Remember, ADH helps us retain our water, so if we're overhydrated, we have less ADH, and our urine will be very dilute, less than 100 milliosmoles. If aldosterone was present, we can have additional ions removed, causing water to become even more diluted in the urine, less than 50 or about 50 milliosmoles. Because remember, aldosterone will remove the sodium, which removes the... And when sodium is removed from the water, it becomes more dilute. And of course, just the opposite, dehydration produces small volume of urine, but very concentrated. That's because there's maximal ADH in the system. With maximum ADH, we have more urine being produced because we're not reabsorbing, or we are reabsorbing maximum amount of water back into the blood. So our osmolarity, or mini osmoles of urine, very concentrated, up to maximally 1200 milliosmoles, and that's in severe dehydration. Almost all of our water is reabsorbed. So let's look at these two processes, overhydration and dehydration, to understand dilute and concentrated urine formation. So in this image here, someone is overhydrated, drinking a ton of water. They're in the shade, so they're not perspiring. So the osmolarity of your extracellular fluids is very low, so we're not going to need ADH. ADH is not released from the posterior pituitary, so that means there's no aquaporins, or very low number of aquaporins, because that's what ADH does. It puts in aquaporins, which are water channels for water to be released, but with very low ADH, there's going to be very few aquaporins in our collecting duct. So when we go through that countercurrent multiplier, once we get to the collecting duct, this is where water can leave and concentrate our urine. But since there's no ADH, because we're overhydrated, water remains in the collecting duct. So even though we're going into the medulla, we're going from 300 to 1200 milliosmoles, which would really want to pull the water out. Well, the water gets stuck in the collecting duct because ADH is not present, so aquaporins are not present. So that will lead to a large volume of dilute urine, lots of water and very dilute. And just the opposite, someone is dehydrated, not taking any water, warm, we have a person running in the heat here, so an increased osmolality of extracellular fluids, so we're going to have ADH release. Because we're dehydrated, we want to retain our fluids, so our posterior pituitary is going to release ADH. And when we have ADH released, that puts a whole bunch of aquaporins up to a maximum amount, depends on the dehydration level, in our collecting duct. So here we have our counter current multiplier that we went through in the past, but all of a sudden we enter the collecting duct. Now water is allowed to leave because of the ADH hormone that's present. So water is leaving, and as the osmolarity that we saw increases in the interstitial space as we go down the medulla, well, water just keeps leaving the collecting duct because of all the aquaporins that are present. So when we get to the end, if we have maximum ADH and maximum aquaporins, we have this isoosmolarity here, so 1200 will equal each other in the most severe case of dehydration. So this is a very small volume of urine, but it's very concentrated at 1200 milliosmoles. So chemicals can affect urinary output. Some that we call diuretics will enhance urinary output. Diuretics cause more urine. ADH inhibitors, like alcohol, if we are inhibiting ADH, we're inhibiting reabsorption. Without reabsorption, we're going to have more fluid in our urine, which is what a diuretic is. There's also sodium reabsorption inhibitors, like caffeine. Some drugs for high blood pressure or edema are sodium ion inhibitors. And since we're inhibiting the reabsorption of sodium, they also inhibit indirectly the reabsorption of water, because remember, water follows solute. There are something called loop diuretics that inhibit that medullary gradient formation. Remember, if you don't have that gradient formation, well, then you can't dilute or can't concentrate the urine. So that will result in dilute or unconcentrated urine. And there's osmotic diuretics, which substances are not reabsorbed. Right? And when substances are not reabsorbed, they remain in the tubules, and if they remain in the tubules, water gets carried with it. For example, high glucose concentration. We talked about that earlier. Right? So if someone has hyperglycemia, and the maximum amount of glucose is reabsorbed, and once the maximum amount is reabsorbed, because of the co-transport system has been maxed out, well then glucose will exist and not get reabsorbed in the tubules. And with substances like glucose or other substances, that pulls water along with it, which would be a type of diuretic. So in a diabetic patient, that high glucose concentration also causes more water in the urine as well.